Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 55th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Elbow, Pain Causes Treatment, Unveiling Solutions for a Pain-Free Elbow, is being recorded so that you may be able to visit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Your elbow hinges to bend and straighten your arm, and it is also a pivot joint, which means it can rotate in place without moving out of its original position. Your elbow pivoting is what allows you to turn your forearm over and to move your palm up and down. In addition, all of the nerves that travel down your arm to your hand and all the way to your fingertips pass through your elbow joint. These nerves are responsible for your wrist, hand, fingers, and thumb movements, and they relay sensations such as touch, pain, and temperature back up to your brain. When our elbows function properly, we don't even give them a second thought. But when they don't, or when we have pain in or radiating from our elbows, well, that dysfunction can consume a lot of daily thought and energy. Tonight, Jason Shrouder-Henry, MD, MBA, will discuss elbow pain, its causes, and the treatments available to alleviate discomfort and promote healing. Dr. Jason Shrouder-Henry is a board-certified orthopedic surgeon specializing in hand and upper extremity. He treats orthopedic conditions in children, teens, and adults, offering a wide range of services, including fracture management, care for arthritis, and treatment for nerve compression. Dr. Shrouder received his medical doctorate from Georgetown University School of Medicine in Washington, D.C., and completed his orthopedic surgery residency at the University of Toronto. He pursued a fellowship in hand and microvascular surgery at the prestigious San Antonio Hand Center under the mentorship of Dr. David P. Green, which was then followed by a fellowship in shoulder and elbow surgery at the University of Toronto. Dr. Shrouder also accepted the Harani Family Scholarship to attend Northwestern's Kellogg School of Management, where he obtained an MBA with a specialization in healthcare management and strategy. In his practice, Dr. Shrouder strives to return patients to their highest level of function through conservative care and, when appropriate, minimally invasive surgery for disorders of the hand, wrist, elbow, and shoulder. His primary research focus involves evaluation of the economic impact and healthcare utilization associated with fracture care for patients, private practices, and hospital systems. He has served as a national panelist at multiple hand surgery conferences, including the American Society for Surgery of the Hand and the American Association of Hand Surgery national meetings, covering topics including optimization of healthcare, value and quality, patient education, and automation of practice management. Through his research, Dr. Shrouder endeavors to improve healthcare delivery to his patients and to optimize their outcomes. He belongs to several professional organizations, including the American Academy of Orthopedic Surgeons, the American Society for Surgery of the Hand, the American Association for Hand Surgery, and the Canadian Orthopedic Association. When he's away from the operating room and clinic, Dr. Shrouder enjoys spending time with his wife and young family. During Dr. Shrouder's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into this question section on your screen, and I will receive them and relay them to Dr. Shrouder immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions for Dr. Shrouder, please contact him via one of the options that will be listed on the slide shown during the question and answer portion of the program at the end of his presentation. One last thing before I turn the evening over to Dr. Shrouder. Please mark your calendar for our next IBJI and YMCA Education Series program on Tuesday, September 24th at 7 p.m. Dr. Mark Breslow will discuss shoulder injuries and disorders, symptoms, causes, and treatment. Thank you again for joining us tonight, and thank you, Dr. Jason Shrouder-Henry, for your time and effort in putting together this program to help us learn and understand more about elbow pain, its causes, and treatment options. Easy for me to say, treatment options. Dr. Shrouder, please take it from here.
Thank you, Karen. I appreciate the warm introduction. Very, very kind words.
I'm sure you earned them.
Well, thanks everybody for joining. So yeah, IBJI reached out to me about doing a talk a few months ago, and I wasn't really familiar with this lecture series, and I've come to learn kind of a lot more about it, and I'm really excited about the opportunity that I've been given to kind of speak to a variety of different of you, of my patients who are kind of out in the public. I know some of my patients are like actually on this presentation in terms of listening, so I appreciate that. But at a high level, what I wanted to do today is give you a broad understanding of some of the common elbow complaints that I see come into my clinic, and help you better understand, as opposed to going down a Google rabbit hole, what your elbow problem may be, and when along that continuing should you seek medical attention, and how you can work to prevent or mitigate any elbow problems that you're having. These ones that I focused on tended to be more chronic in nature. So a couple of them were acute, but mainly they were chronic issues. And I focused on that because elbow is, to put it mildly, very complex. So in the vein of getting through the talk in a reasonable amount of time and allowing everybody to kind of digest the information, we focused mainly on chronic conditions. So the conditions that we're going to highlight today, and I'll use a mixture of medical terms and kind of layman's terms for the injuries that you'll see. We want to be using language that we're all kind of familiar with. So tennis elbow or lateral epicondylitis, golfer's elbow or medial epicondylitis, ulnohumeral osteoarthritis, also is colloquially known as elbow arthritis, cubital tunnel syndrome, distal biceps tendonitis or tendinopathy, lateral ulnar collateral ligament sprain or ulnar collateral ligament sprain. Think of that as a sprained elbow. Another popular one that I've been seeing a lot more of recently is Olecranon bursitis, whether that be septic or chronic. So we'll start with lateral epicondylitis. So this is commonly overuse injury caused by microtrauma to the common extensor tendon, which originates at that lateral aspect of your elbow, the outside portion of your elbow. It can be due to repetitive wrist extension, repetitive grip activities, repetitive lifting with the hand in a pronated or flexed position. Most of my patients kind of fall in within the age 30 to 50 range. We do have a grouping, I would say, like that are 60 plus, but most of them are 30 to 50 years old. They present with pinpoint pain, and those of you who've had it know it's pinpoint pain right over that bone on the lateral aspect of the elbow, and it's sharp when you're gripping or lifting, or when you come into my office and I push on it. Typically, we make the diagnosis on exam by coming into the office and I assess you, or you meet some of these symptom criteria. Very rarely would I start with an MRI, just because it typically doesn't change management. I usually only move toward getting an MRI if a patient has recalcitrant symptoms that are refractory to the typical treatment that I provide. So this is a picture of the elbow. The circle is where the extensor tendons start, and those tendons form a confluence of tendons that then form muscles that then turn back kind of into tendons and go to your fingertips and allow you to extend your fingers, extend your wrist. So they're important, and they're why when you have this tennis elbow, you get pain when you bend your wrist back or when you extend your fingers up. So good news, 95% of patients will have resolution of symptoms without surgical intervention. And anecdotally, in my practice, it's closer to 99. Very rarely have I had to do surgery. So that's good to know. Typically, my treatment algorithm involves really exactly what I've listed here. A counterforce strap brace that you can get on Amazon. Basically wraps around your elbow, just kind of down from that bony prominence, and stabilizes those tendons. We also have you do occupational or physical therapy, where we work on range of motion, strengthening and mobilization of those tendons. We also, at the time of the visit, depending on severity, I typically offer a steroid injection into the origin of those tendons. So the steroid injection kind of goes right in and around here and diffuses around the tendons, okay? And then lastly, which is tough because a lot of the time this happens in people who are really active, is activity modification. So taking a break from heavy lifting at the gym, lowering your weight, reducing those activities that aggravate the symptoms. Another thing that I don't personally do, but some of my partners have, do in their practice is PRP injections. I've just found that typically 1 or 2 rounds of steroid injections is effective in resolving the symptoms. So I usually don't even have to get to that level. Surgery, typically a last resort. The surgery involves basically debriding that diseased part of the tendon, and then kind of reapproximating the remnants of the tendon origin. Again, very rare, an effective surgery, but typically unnecessary. Probably the most important thing to understand about this condition is that it has a disease history, okay? So what that means is over a 1 to 2 year period, this typically goes away with or without any intervention. The reason we do these interventions is because if we did nothing, you would be in pain for 1 to 2 years, which obviously nobody wants. So we do these interventions to mitigate the pain, decrease the pain until the tendon pathology burns out, basically kind of resolves on its own. So next one is golfer's elbow, another common one, very similar to the tennis elbow, but on the inside part of your elbow, okay? So it's going to be caused by repetitive wrist flexion, forearm pronation, lifting with the hand in a supinated position, or flexing the wrist and elbow with heavy weight in it. Again, similar age distribution to medial epicondylitis, to lateral epicondylitis, sorry, and occurring typically in people 30 to 50 years of age. Symptoms, again, similar to tennis elbow. Pain, burning sensation on the inside of the elbow, increased pain with wrist flexion, lifting and gripping of heavier objects. And again, this is typically, you come into my office, we do an exam, and we kind of know right away. We rarely get an MRI because it's often unnecessary and doesn't change management. So this is another picture of the of the elbow, where the tennis elbow, the golfer's elbow is on the inside of the elbow. It's inflammation on the inside of the elbow. So treatment-wise, we do a counterforce strap brace again, except that there's kind of a thicker part of the brace, and that is preferentially placed on the inside of your elbow to stabilize the tendons on the inside of your elbow. Again, occupational therapy is commonly used with a focus on modalities. So modalities means TENS units, ultrasound to help calm down the pain, soft tissue mobilization, stretching, and again, the other big one is activity modification, which is crucial for this condition. Now, a caveat here is some surgeons will do a steroid injection into the medial side. I have erred towards not doing that, even with ultrasound guidance, because your ulnar nerve basically runs about a half a centimeter away from you where you would have to inject for this to be effective. And there's just a risk of injury to that nerve. So I have not done that in practice, and I have had good success without doing it. The vast majority of cases, again, burn out in 1 to 2 years. So ulnohumeral joint arthritis, that again is elbow arthritis, basically. Okay, so it's wear and tear or loss of cartilage on the articular on the surface of the bone at the elbow joint. Causes include previous injury to the elbow joint, whether that's a fracture dislocation of your elbow, heavy activity at work, or recreational activity that puts continuous stress through your elbow joint. Typically occurs in my patients age 50 and older. I do see it in young people. However, that's typically in heavy laborers when they're younger, as in less than age 50. Key symptoms for ulnohumeral osteoarthritis are pain and decreased range of motion. So if you're at home and you're, I have this elbow pain and my range of motion is limited, that's a big indicator, okay, in terms of you having possibly joint arthritis. And for my elbow joint arthritis patients, similar to any patient with possible arthritis, we get x-rays and assess for narrowing of your joint space. We look for excess bone fragments or bone spurs that may form when you get arthritis, just like you would of the shoulder, wrist, joint. I would say rarely do I get advanced imaging to evaluate for arthritis. Typically, arthritis is a X-ray diagnosis. Treatment-wise, especially in my patients who are on the earlier side age-wise, meaning around 50, it's conservative, conservative, conservative. Activity modification, corticosteroid injections every 3 to 6 months to decrease the pain, therapy to help improve the range of motion, NSAIDs like Advil or ibuprofen or Celebrex or meloxicam, which some of you may have heard of. These can provide meaningful symptomatic relief for elbow joint arthritis. In the younger patients who have symptomatic arthritis and they're not responding to conservative treatment, we consider arthroscopic debridement or open debridement of the elbow joint to quote unquote clean up the joint. And that doesn't cure your arthritis long term, but it gives you meaningful temporary relief, like 2 to 3 years of relief. Similar to other joints, there is a joint replacement surgery for elbow arthritis, similar to, let's say, a shoulder replacement or a hip replacement. The main issue and why we don't do it very frequently in practice in terms of doing elbow replacements is that there is a significant weight restriction on that implant that is unlike any other joint replacement we have in the body. It's 5 pounds, which renders your upper extremity much less useful than it otherwise would be. So another big one that comes into clinic quite often is cubital tunnel syndrome. So this is compression of the ulnar nerve at the elbow. And the ulnar nerve provides sensation to your small and ring finger, and also provides muscle function to flexor tendons that flex your wrists and allow you to have muscular function within your hand itself. It's correct in stating that the exact cause is often unknown. It can be related to trauma. It can also be related to arthritis. So if you can imagine, if you have a painful, stiff elbow, your nerve isn't gliding like it typically would, and it stays in a kind of flexed position, which you interpret as numbness and tingling or pain in your small and ring finger. So that's another kind of correlation that we see occur. When you come into clinic, in terms of assessing the cubital tunnel syndrome, I'm looking to see if palpation of that ulnar nerve on the inside of your elbow is recreating any symptoms of numbness or tingling or shooting pain down your hand. Often patients will come in and they'll say, when I'm at my desk at work, my hand wants to fall asleep, or when I lie down at night and my hand wants to fall asleep. When we lie down at night, we often flex our elbows and our wrists. Everybody thinks they sleep differently than everybody else, but actually most of us sleep just like that in some form or fashion. So that can cause pain, numbness, and tingling at the elbow with radiating symptoms to the ring and small finger. And it can also lead to weakness in the hand. So big key test for me in clinic that I'll order is a nerve conduction study, where we look at the firing or the speed of your nerves and the firing of your nerves in your upper extremity. So that's your ulnar nerve. We also look at the median nerve because they can often happen together, where you get median nerve compression, which is layman's term for carpal tunnel and cubital tunnel at the same time. And then we also do an EMG, which looks at the function of the muscle during that time and the nerves that innervate that muscle to see whether or not the muscle has started to lose function. So a lot of cubital tunnel I'm able to treat successfully conservatively with extension splinting to the elbow while you're sleeping. Nerve glide activities, which are basically a series of stretches that allow you to stretch the area that the nerve is entrapped in and basically improve the gliding of the nerve in that area, which is the medial aspect of the elbow, the inside of the elbow. Another big one that seems simple, but I find that patients, have a lot of success with this, is adjusting your ergonomics at your workstation, especially if you work at a computer all day. And that involves sitting with your elbows extended as opposed to flexed. Because when you sit with your elbows flexed for, people are working pretty hard these days, over 6 to 8 hours, that is kinking that ulnar nerve, and your mind's going to interpret that as numbness, tingling, and pain in the elbow. From a surgical standpoint, typically what we do, or what I do in practice, if we get to the level where you're not responsive to non-operative intervention, we do a cubital tunnel release, which is basically going to that inside part of the elbow, releasing that soft tissue that's compressing the nerve. Occasionally I have to do a transposition, which is moving the nerve to a different location on the elbow so that it no longer can get kinked. Recovery is around 6 weeks, and therapy is typically not needed. The one big caveat for the surgery, for all kind of you out there or patients out there who have cubital tunnel symptoms, it is just fundamentally not as reliable as a carpal tunnel surgery. So the reason why I try to really push my patients to do conservative management if they can is because the surgery for cubital tunnel release, just based on the literature, does not 100% guarantee that you're going to have a complete removal of your symptoms. It typically improves your symptoms, but making them completely disappear is not usually the case. Distal biceps tendonitis, tendinopathy. So again, this is inflammation of the distal biceps tendon due to repetitive activities. If you can imagine weightlifting, strength training, it's pain at the anterior aspect of the elbow, radiating right up into the biceps. So a lot of the diagnosis is clinical. But because, as you can imagine, if your biceps tendon is inflamed, there's a risk that it can be torn. So in a lot of my patients that come in with strictly this complaint, we actually do get an MRI to make sure that there's no partial tear of the biceps tendon, because that can often resemble biceps tendonitis. So I usually will get an MRI on these patients. If it ends up being tendonitis, treatment is activity modification, rest, anti-inflammatories, and physical therapy. Surgical intervention is very rarely needed, and typically, I have only had to do that when there is a complete biceps tendon tear or a partial biceps tendon tear, both of which can lead you to have decreased function with flexion and supination strength. Another common one, especially in my pediatric population, is sprain of the lateral ulnar collateral ligament or the ulnar collateral ligament. These can be acute or chronic injuries. Depending on how you, typically this occurs as a result of like a fall or twisting mechanism. You can get pain either on the inside of your elbow, which would be ulnar collateral ligament, or on the outside of your elbow, which would be lateral ulnar collateral ligament. They can often be associated with an elbow dislocation. So anytime I get an elbow dislocation, I automatically will get a MR arthrogram, to evaluate for lateral ulnar collateral ligament injury and ulnar collateral ligament injury. So the picture on the left shows the ulnar collateral ligament. My cursor, the white cursor over here, and the arrow are pointing to the bands of the ulnar collateral ligament. This is the ligament that's repaired in Tommy John surgery. The picture on the right demonstrates what's called technically the lateral ulnar collateral ligament complex. So without getting too technical, it's made up of about 4 different ligaments, the most important of which is this lateral ulnar collateral ligament. So as I mentioned, we assess this in clinic, but often need an MRI or MR arthrogram to be definitive on whether or not there's a sprain, partial tear, or complete tear. Partial tears and sprains typically are treated with conservative management in the form of anti-inflammatories to decrease inflammation, a hinged elbow brace, physical therapy, and gradual return to activity. I have found in my practice that the hinged brace, although very cumbersome, is very effective in stabilizing that elbow while allowing you to still have a good range of motion at TEM therapy and still build the strength of the muscles around your elbow while protecting that torn ligament. From a surgical standpoint, what I can do is repair the ligament with a high strength suture construct to reinforce it, or reconstruct the ligament with cadaveric tendon graft. So a big one here to hit on is Olecranon bursitis, okay? I have seen this, twice in the last week. So the big key for those of you at home that you want to separate is what it says there basically. Is this septic? Is this an infection? That's what sepsis means. Septic means infection. So that's going to be a red, swollen, hot elbow, posterior aspect of your elbow, with typically fevers and chills, okay? Now, a lot of the time people will say, how did it happen? Did I get a bug bite? Half the time we don't end up knowing why it happened or how it happened, but we know what it is when it presents. If you're having those symptoms at home, you need to go in and see urgent care, myself, for treatment with antibiotic management. The other presentation is more of a chronic irritation, tenderness, and inflammation about the posterior aspect of the elbow without the infection, fevers, chills, symptoms added to it. And it can be related to acute trauma or repetitive pressure placed on it. And that we kind of already went over. So for the septic bursitis, if I'm seeing you in clinic, typically we'll start with oral antibiotics, and I'll assess you pretty closely. Like the patient that I saw on Tuesday, I'm going to see them back in clinic tomorrow. So it's like a 2 to 3 day window to see if we're progressing on oral antibiotics. If you're not, I bring in my infectious disease colleagues, and we consider IV antibiotics. And if that's not effective over a 1 to 2 week period, then we move toward doing hospitalization, blood work, an advanced imaging in the form of an MRI to rule out infection that has seeded your bone. Another key point here with the Olecranon bursitis, okay? Older teaching, say pre-2010, 2011, was to drain the bursa, put a needle in there and drain it. That is definitively not what we do anymore, okay? We have learned that in a chronic case, you can introduce infection, so you can make a bad situation worse. And in a septic case, you can put the patient at risk for significant wound healing complications after surgery. So we very, very rarely do that. And it's only in patients who are not responding to conservative management and are at risk of becoming septic because their bursitis infection is seeding their blood. I mentioned we bring in our infectious disease colleagues. From a surgical standpoint, if we do go in, we typically remove the bursa as it's the offending agent, and we wash out the area as well, and reapproximate the tissues. Then in my hands, I actually split the patient in extension for 3 to 4 weeks after surgery to make sure that the wound doesn't break down. We don't have wound healing complications. I bring in my wound care colleagues to also help with wound management postoperatively. I want to thank all of you for taking the time. I know we all have families, and you're kind of listening to me talk for about an hour in the evening, so I appreciate you taking the time. Like I mentioned, I specialize in hand and upper extremity surgery, specifically hand, wrist, elbow, shoulder trauma, so that is fractures. And I also do elective work in the hand, wrist, and elbow, with also performing shoulder replacements as well. So we are, think we offer quality care and in a timely manner. So anybody has any questions in general or has any issues that they'd like me to assess, I'm happy to do so. And that's it. Thank you.
Awesome. Thank you, Dr. Shrouder. That was great. And I love how you use lay terms to make it very clear to everybody. I have a quick question. Are you seeing more septic bursitis of the elbow or more chronic? You've said it's becoming more and more common.
I would say that I'm seeing more chronic, but septic does come in as well. It's probably, I'd say, 1 septic for every 2 chronic. And like I mentioned, a lot of it can be treated with antibiotics, activity modification, protecting that elbow with an elbow pad. We have a regimen of ACE wrap that we use, where we have the patient wrap their upper extremity 3 times a day, 30 minutes each time, in order to basically push out the swelling and inflammation that's in there.
Wow, fascinating. Thank you. All right, we're going to go back to the beginning. The first question that came in was, could you please explain how a strap brace helps with tennis elbow?
Right. So what the brace does is it basically stabilizes the tendons. So when your tendons aren't stabilized, they can be irritated because you basically have a area that's already irritated, and then the tendons are moving around that area and getting further irritated. So if you stabilize them with this brace, it decreases that movement, which decreases that irritation.
Great. And you had mentioned that it's highly successful. So if someone is
I've had good, if we're talking about tennis elbow, I've had good success with a regimen, and it's often multimodal, right? So it's not just the brace, right? It's the brace, the injection, the activity modification, the stretches. And for patients, it's difficult. Like that's 4 things that I just said that if you do, you have like a 95% success rate, right? But that's a commitment.
Yeah, for sure. All right, thank you. The next question is, can chronic tennis elbow result in arthritis or other chronic inflammations or conditions?
So typically, chronic tennis elbow will not result in arthritis. That's just not how the disease pathology works. It usually, as I mentioned, burns out and kind of resolves on its own. So I wouldn't, they're just not the disease pathology. They're not related necessarily.
Okay, great. And when you say it burns out like that, do you think it's because people end up modifying their activity because it hurts so much after 1 to 2 years? Or do you think it, like if they keep doing what they're doing through the pain, does it just something happen within the body that it just sort of stops?
Yeah, I think your body just heals it. That's not, I think, that's like what the science has shown.
Wow, even if people don't change their
1 to 2 years to do it. That's the tricky part.
Got it, fascinating. All right. The person who asked the question about the tennis elbow turning into arthritis also asked, when you were talking about arthritis, you used the word disease. He said, is there a change in the tissue or is it just wear and tear on the tissues?
That's a good question. So technically speaking, not to get too technical, the tissue itself, wear and tear causes the tissue to change. So that's the way to think about it. That's the way to think.
Got it. Okay. And that makes sense to me. I hope it makes sense to that person as well. All right. So this one is a little bit personal, but I thought it related to a lot of people. So I thought I would ask the question anyway. It's kind of long. This person was just diagnosed with tennis elbow, probably due to racket sports. They stayed off their elbow for 9 months due to pain. Now it's much better, although not quite 100%. Should they use heat and cold packs after playing and use them and use the arm strap for the next whole season? What about massage? Would that help? They're trying to keep it from getting inflamed again.
Right. So we're 9 months in. I definitely think the strap the brace should be used. I think if you don't have a home exercise program, that is definitely going to be something you're going to want to do. I think that heat and ice is effective, but I didn't mention it in one of my 4 main treatment modalities because it's less effective than those other 4. And all patients are different, so you don't want to overgeneralize, but I have found that that's not one of the major things that kind of changes your outcome or relieves your symptoms. If you're getting relief from it, I think that's fine to go ahead and do it. But what will really help decrease kind of recurrence or flare-ups during the season is going to be the brace. It's going to be stretching and strengthening exercises that you do on a consistent daily basis, and possibly a steroid injection if you do get a flare.
Great, thank you. That makes a lot of sense.
They mentioned massage too.
Yes, that was
massage. Yep. Just not a lot of data on that for that specific condition. I'd say that it's not going to hurt you, and if you're getting relief from it, it's fine. But I wouldn't make that a pillar of my treatment.
Great, thank you. That makes a lot of sense. Okay, can you discuss, and I'm sorry, I haven't read this one yet. Can you discuss your views on peptides like BPC 157 or TB500 and use for golfer's elbow?
I'll be honest, I'm not quite up to date on the literature in relation to peptides for golfer's elbow. As I mentioned in my talk, I've had partners who use platelet-rich plasma for golfers or tennis elbow. The literature on anything but steroid is very limited and inconclusive. That's what I can tell you for sure. So, the way I look at things like PRP is if you've exhausted the standard of care and you're in that gray zone where you're pretty early in the condition, like, 3 to 4 months in, you've exhausted that standard of care and you're still in excruciating pain, PRP is not unreasonable to consider, with the understanding that it may do nothing, right? Or it may make you better. But there's not enough data. When doctors say it's inconclusive, it means it's been studied and tested, and it versus a steroid is no better.
Yeah.
Or it didn't cause a meaningful improvement. So we're not inclined to change the standard of care until we see that.
Got it. That makes sense. Thank you very much. All right. This person asks, how much physical therapy is enough to determine if another course of action is needed? And they say 8 weeks of virtual physical therapy and have not improved. And on top of it, the therapy for the right elbow led to bursitis in the left elbow. Not sure exactly how that happened, but what are your thoughts on that?
Yeah, we'll agree to disagree there. But I think that, you know, therapy, again, we're going to circle back. Therapy is one aspect of a multimodal treatment algorithm for tennis elbow. So is there a brace involved? Have you had a steroid injection? Are you doing the activities on a strengthening activities on a daily basis independent of therapy? Have you rested from your day-to-day activity that causes it? Let's say it's a sport that's causing it. Those are things that have to be evaluated before we say, like, throw our hands up at therapy, right?
Yep, thank you. Makes a lot of sense. All right. Are there any cons to having an injection? And I'm guessing they're talking about a steroid injection.
Right, I'm assuming that too. So risk of the injection, just like I tell all my patients, okay, infection, bleeding, injury to the nerve, injury to the tendon there, injury to the blood vessel there, okay? And you can also get skin discoloration. These are all unlikely, but a possibility, okay? The risk of steroids, and I think this is very important for kind of everybody on the call, on the presentation to understand. Steroids are, you know, have a more meaningful risk when they're injected chronically into areas where they're decreasing inflammation about a tendon, okay? If you do that chronically, 3, 4, 5, 6 injections, you can cause the tendon to rupture. This has been studied. We are aware of this, okay? Steroids being injected into a joint that is moderate to severely arthritic typically can be done with reasonable frequency every 3 to 6 months to provide pain relief. Steroid injections into joints where patients are much younger and it's early stage osteoarthritis, we've learned that we cannot with the same frequency inject because it can counterintuitively accelerate the arthritic process. So I have a different kind of tolerance for how much I inject in people who are, let's say, sub 50 in early onset arthritis versus people who are 65 plus and severe arthritis, where you're not worried about destroying the joint because the joint's already severely damaged.
Yeah, got it. Got it. That's very helpful. And I think a really good explanation for everybody with regard to steroid injections. So thank you. All right, we're going back to tennis elbow. That seems to be a really common topic tonight. With tennis elbow, is there accompanied swelling of the muscle around the elbow?
Yes, that's correct. That's correct. It's not 100% of the time. I'd probably say about 30% of my patients have swelling. And that's when it's kind of like really aggravated, really angry. Yeah.
Got it. Great. Thank you. And then someone else asks, should you wear the brace for tennis elbow or probably golfer's elbow as well? Should you wear the brace 24/7 or just during activity or just during sleep? And when should you wear the brace?
Early on, first 6 weeks, I tell my patients, you wear that when you're doing day-to-day life. So during the day, you have that on. Then as your symptoms improve, then you wear it when you're doing an activity that's going to flare it, like tennis or like golf. But for the first 6, that acute phase, we want to really hit it as much as we can, and then we want to maintain and eventually get rid of the brace.
Gotcha. Do they need it while they're sleeping?
No, that is no.
So just during your daily activities, take it off
Yeah.
at night.
Mhm.
Great. Okay. Thank you. And I suppose they could take it off if they're sitting and watching TV or something like that. If they're not using that arm,
Correct.
you can take it off. You know, sometimes people will say, you know, it pokes them here or scratches their skin or something. They can take it off when they're not doing things. Super. All right. Let's Let's see. All right, I'm going to my other list of questions now. Okay. Oh, can you get gout in your elbow?
Yeah, you can.
Okay.
So those tend to be sicker, hospitalized patients. I think I've had 1 or 2 patients who've come into my office with gout. It's more of like an acute, they came to ER, excruciating pain, elbow was aspirated, found to be gout. You know, those are people I usually see in the hospital.
Okay, great, thank you. And if someone has fractured their elbow, are they still able to move their elbow? Is that a common thing to have happen, that you can't move your elbow if it's fractured?
So it's tough. You know, I always tell my patients, right, there's a lay understanding that if I fractured something, fractured means broke, same thing,
Yeah.
then I won't be able to move it. It unfortunately does not always work like that.
Got it.
So I would not make that correlation. I would say typically when you fracture in your elbow severely, you can't move it. But I've had patients who've had small chip fractures, impaction fractures, and they can move their elbow just fine. It hurts, but they can move it. So, you know, we don't want to conflate, you know, fracture and movement, because it's patients often come in. I didn't come in for 2 to 3 weeks because I can move it, so there's no way it could be fractured. It's like, well, actually, you know, none of us have X-ray vision. That's why we get the X-ray. So now it's fractured. You know, so you don't want to find out something the hard way because you thought you used the movement and fracture relationship, which isn't a real relationship.
Great. So when in doubt, people should come in and get it checked out.
Yeah.
Yeah, and especially if there's a trauma, like if you fell on your elbow or, you know, hit it so hard that it's hurting days later, it sounds like that's something, get it checked out.
Exactly.
Okay, great. And let's see, are there ways that we can prevent getting these types of things like tennis elbow, golfer's elbow, those kinds of things?
Yeah, so, you know, a lot of it when it comes to tennis is good technique, good form. Sometimes even despite that, it still happens. And then a lot of it is prevention, right? So let's say you get it once, a lot of it's prevention. So the prevention comes from doing those exercises on a routine basis where you're stretching your elbow, stretching the tendons about your elbow, working on strengthening them, incorporating that into your like, you know, weekly workout routine.
Great. And you explained how tennis elbow and golfer's elbow happen. And oftentimes people will have tennis elbow and golfer's elbow, never having played a day of tennis, never having golf.
Right.
It can happen from weightlifting. It can happen from carrying a briefcase. You know, there are different things that can cause that. So again, when in doubt, you know, get it checked out and come and find out, do I actually have this, and can it be helped by doing these things? So Dr. Shrouder, thank you so much for your time tonight. We are good for questions. We've gotten them all answered. And unless any more pop in at this last minute, I am going to thank you very much and let you go. We appreciate your time and the effort you put into this. And thank you for sharing all this great information tonight, Dr. Shrouder.
Happy to do it. It was an honor to be able to, you know, share a little bit of insight with everybody. And my email address is up there. I hope everybody can see it. If they can't, you can put it in the chat. If you have any questions or want to get in to see me, you know, I'm happy to take care of everybody. Okay.
Awesome. We appreciate it. We're getting lots of thank yous coming in as well. So thanks again.
Thank you,
guys.
All
right. Have a great evening. Take care now.
Take care, guys. Bye.
Bye-bye.